everyone. I hope everyone had an opportunity to reminisce and chat with our presenters from this morning. It's now my great pleasure. We have Dr. Jennie Johnstone back in Edmonton today to present the second annual Dr. Jeff Taylor Lectureship. This lectureship was established in 2020, although not first launched until last year due to this pandemic that that happened. But this lectureship was established in 2020 by Prue Taylor, Jeff's wife, who is joining us today in our audience, and family in conjunction with Division of Infectious Diseases and the University of Alberta through an endowment. Jeff was a member of the Department of Medicine and Division of Infectious Diseases since 1985 and made numerous important contributions, too many really to list here, to the University of Alberta and Alberta Health Services, as well as nationally and internationally. Within the division, he co-founded the Northern Alberta HIV program, and in Alberta, he established the first hospital infection control unit. He was also a founding member and an integral part of the Canadian Nosocomial Infection Surveillance Program, which led to the development of a national surveillance of hospital-acquired infections and antimicrobial resistance in Canada. He was a tireless patient advocate, particularly for the vulnerable and stigmatized populations, and he was a dedicated mentor, providing guidance and support to many trainees and junior faculty over the years. And one of those trainees was Dr. Jennie Johnstone. And she will deliver our keynote address today, but I'm going to turn it over to Dr. Smith to actually give us a further introduction of Dr. Johnstone.
Thank you very much. So it is certainly my pleasure to introduce my friend and colleague, Dr. Johnstone. Dr. Johnstone and I were both mentees of Dr. Taylor, so it's really exciting to have her back here. So Dr. Johnstone has been an infectious diseases physician at UHN Sinai in Toronto and the medical director of infection prevention and control at Sinai Health since 2018. She is currently an associate professor in the laboratory medicine and pathobiology at the Dalla Lana School of Public Health at the University of Toronto. And she's newly the U of T divisional director for infectious diseases. So Dr. Johnstone obtained her medical degree from Dalhousie University. She then moved to Edmonton, Alberta, where she completed her internal medicine training and infectious disease training at the University of Alberta. Following her residency, she completed a clinical research fellowship in Edmonton and then moved to Hamilton in July of 2008, where she practiced infectious diseases at McMaster University and completed her PhD in health research methodology. After her PhD, she launched her program of research as an IPAC physician at Public Health Ontario, and she practiced infectious diseases at St. Joseph's Health Centre in Toronto. And she served as the IPAC medical director there as well. Her research interests focus on prevention of healthcare-associated infections, and she has published more than 125 peer-reviewed research articles in this field, and has participated widely in the development of clinical guidelines on topics such as COVID-19 and other IPAC topics on behalf of the National Advisory Committee on Infection Prevention and Control for the Public Health Agency of Canada, Ontario Provincial Infectious Disease Advisory Committee, and Ontario Health Toronto Region Working Groups. So welcome, Dr. Johnstone.
All right, well, can you hear me? Thank you very much. Thank you to Karen, Stephanie, and others who invited me here today. Just before we get started, I did just want to say what an honor it is to be here at this lectureship. And we glossed over it in the bio, but I did do a clinical fellowship here, but that I came to understand that I wanted to do research late. And so that fellowship was unfunded. And Jeff realized that that was unfunded and said, how are you going to support yourself? So I had not really thought that through. And as it happens, Sarah Forgy, who I'm sure everyone here knows, was going on her 4th mat leave. So Jeff said, why don't you fill in for Sarah for this year to do be the acting medical director of IPAC for Stollery Children's Hospital, which working with some of you in the field, I'm still here. And what that meant was I could do infection prevention and control under the mentorship of Jeff, truly, and I learned so much through that year. So I was on my own, but really, truly supported by the exceptional ICPs as well as Jeff. And doing that in conjunction with research, I was able to see how these two things could come together, and that really laid the foundation to my career so far. So I am intensely grateful to Jeff, and again, just want to emphasize the privilege it is to be here today. So with that in mind, I wanted to choose a topic that I thought that he would like, and I can only hope that you will enjoy it too. So I don't have any financial conflicts of interest to declare, but as mentioned, I have sat on a lot of committees, and so I may promote them in a way that perhaps you may not necessarily agree with, but I am currently the chair, and I sit together with Stephanie on the FAC National Advisory Committee on IPAC. I do chair the Toronto Region IPAC Hub Coordinating Table, which we'll talk a little bit more about later on. And I was the past chair of the Provincial Testing Strategy Expert Panel, which again made recommendations through the pandemic to our CMOH. And then I was able to sit as a member on a number of other groups, which again, I will be highlighting their work here today. So, COVID-19 had a huge impact on long-term care. And so I'm going to try, and I will be hammering home that impact on long-term care as we move through this. I wanted to share and review the IPAC learnings and hope that we can remember them, but also to outline the emerging threats to IPAC within this sector. So for those of you who are in IPAC, you will have your own experiences, and what I'm going to describe, you will have your own examples. But I realize that not everybody here will have had that experience, and I want to take you back to wave one, when these outbreaks started to unfold within long-term care. And so this is an example of just one of many outbreaks that occurred within long-term care within Toronto. Normally there's about 123 residents, but at the time of the outbreak, there was 113. And it had varying residents. It actually skewed slightly younger, more male, because it had more of a skew towards mental health and psychiatric problems rather than full long-term care, but it is a fully functional long-term care home. But the average age was 78. And so going back to 2020, and again, this is in Ontario, visitor symptom screening started on March 9th. Staff screening started March 11th, and that was the same day the pandemic was declared. Starting March 13th, there were no visitors allowed, any essential care partners or no visitors, period, full stop. March 22nd is when our Ontario government implemented limiting working between multiple facilities. And it was until April 8th that universal masking was implemented within long-term care. And then April 14th is when wider asymptomatic testing occurred. So again, I realize that none of you probably remember all of this. I myself blocked a lot of it out. And again, this is a messy, and I'm just going to highlight a few points here. So this is the epi curve of this specific long-term care home outbreak, which included both residents as well as staff. And truly, the first symptomatic residents were back on March 13th. So going back in time. So a number of residents became sick, and to the credit of the home, they knew that there was a respiratory outbreak ongoing. And in fact, they declared, together with our local public health unit, a respiratory outbreak. But because of such delays in testing, they knew, I think it was not flu and not RSV, and they just declared respiratory virus outbreak NYD. The first staff person became sick here on March 19th, and then their PCR was confirmed on March 23rd, so 4 days later. And it was at that point they said, oh, well, maybe we have a problem. So additional testing, so the red bars are staff and the blue bars are residents. And so you can start to see how it just started to unfold. But it wasn't until April 1st, April Fool's Day, that the COVID-19 outbreak was actually declared. But by then, this was already a raging outbreak. Again, reminding the provincial universal masking didn't come into place till April 8th. So really, this was just spreading like wildfire. And then again, it was here, this hospital involvement, which is the day that I was brought into, the senior leadership office and said, by the way, we've just been informed that hospitals have to help support infection prevention and control in long-term care homes. Here are your homes. This one's really out of control. Can you fix this? So I said, oh, okay. So, but on retrospect, I didn't do anything. I didn't do it. Look, like this is the definition of a terrible, terrible outcome, right? Like the outbreak just burned its way through with no interventions whatsoever, except for us coming in and saving the day. And, obviously it was completely done. It wasn't formally declared over until May 22nd, but at that point in time, there was 152 cases between the staff and the residents. So in terms of the resident cases, it was 97. And I can tell you because of some underlying personalities within the home, which I've since learned to get to know these individuals, they refused testing. And so quite frankly, the attack rate was higher than this for sure. And then in terms of staff cases, there were 55 staff. So that was roughly a third of all the staff. So 20% required hospitalizations and almost 22% of them died. And again, this was a slightly younger population. I can tell you we were involved in another outbreak in a very elderly home. I think the average age was 98, and that had a 60% mortality rate. So, I mean, it really was shocking. And this is so Dylan Kane, who was the IPAC fellow at the time working with us when COVID hit. He was able to work with an architecture firm where he was able to really detailed map this outbreak. And I just wanted to highlight, as we're going to talk about some policy pieces, I wanted just to highlight a few things. So this is a floor plan of one of the floors. And what you can see is there's many multi-bedded rooms. So a 4-bedroom here, 4-bedroom here, 4-bedroom, 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 4-bedroom. And this one has the bonus of actually having a Jack and Jill between these 2 4-bedrooms. So it's 8 people sharing 1 bathroom. And I can tell you, I don't care how good at infection control you are, nobody can prevent something running through a home like that. So what happened was the first person became sick. They had 1 empty room. And so they transferred that individual out. But of course, there were 3 contacts still there. And so what happened was, of course, additional cases started popping up, including the roommate, who was a high-risk exposure, knowing what we know now. And then at the end of it, you can see really, truly, again, all of the colors don't matter here really, but you can see it basically went through the entire home. And the last point I wanted to make is, so these are all the staff that were affected. And so they only had 4 housekeepers. And so what happened was housekeeper, 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 housekeeping all became sick. So when we got involved, there was nobody cleaning, there was nobody available. As well, the senior leadership of the homes had all gotten sick as well. So there's one guy who, on retrospect, told me a couple months later, he said, I did lose my taste in the middle of all this. But, moving on. So, so we had no administrative staff, so nobody to organize. We had no housekeeping, nobody to clean. And again, all of the staff were off sick as well. This housekeeper they hired, but then got sick right away. So, again, it was really, really, really challenging. And one of the other aha moments was there was no occupational health. Occupational health doesn't exist as an entity within homes. And so there was nobody to bring people back. So who was actually going to be calling and bringing people who went off work and bring them back? So in terms of the observations, the easy things, low-hanging fruit was that we needed more IPAC knowledge and capacity within long-term care homes. There was no surveillance. Yes, yeah, we do screening. They didn't know how to do that. There was no infrastructure to do that. Turnaround, the actual testing and turnaround testing, I won't be talking about that too much, but we can certainly get into that in the discussion period. But that was a huge barrier. PPE, there was no PPE, there was no knowledge of PPE, no knowledge of donning and doffing. I mean, it was really just like not there at all. No ability for the health system to scale. So I think this is something that you guys did better in Alberta, but these were islands off in and of themselves. And so there's nobody to come, who to draw on, who is going to come and help. And then lack of capacity. So environmental services, occupational health, I mentioned wasn't just IPAC, it wasn't just staffing, it was everyone across the board. And again, the importance of private rooms and private bathrooms. So this is one of the science table briefs. And so we were fortunate in Ontario to have the science table that turned out some fantastic work. And this is from one of the briefs where you can see that on this graph was the number of resident deaths in total. So again, here's Canada here. We didn't do so badly compared to our peers, but where we really fell down in wave 1 was that 80%, you can see this is where this is blown up, 80% of all the deaths were in long-term care. So remembering that long-term care home only comprised 0.5% of the population, this is just an absolute travesty. And so some people say, well, there's old people and they're going to die anyway, and et cetera, et cetera. And, you know, again, which obviously drives me nuts. But again, so we said, fine, you want to think that? This is when you compare those in long-term care home to the adults 80 plus in the community, this is the orange. You can see with wave one, in terms of the COVID mortality, was exceptional in wave one, terrible if you looked at the area under the curve for wave two. The miracle of vaccines, yes, they work. Wave three and wave four, where there was effectively no cases. And then again, Omicron, when it really overwhelmed, and then you could start to see the blip there in the adults 80 plus in the community. And so when you look at the COVID-19 mortality per wave in absolute numbers, so in wave one, 2.5% of the entire long-term care community died, close to 3% in wave two. And then it wasn't until, again, vaccines where it really started to fall. And then again, it was challenged again with Omicron, but really wave one and wave two were just terrible. And then the case fatality. So what you can see again in wave one, it was over 30%. So not only did we have overwhelming cases of COVID-19 in this population, 1 in 3 died. That dropped to 20%. Probably we were just better mobilized for wave two, but you know, it was effectively still the same virus. And then wave three and wave four, primarily those that weren't vaccinated, it did continue to fall, and then it wasn't until 5% with Omicron. So what went wrong? There's a lot of stories. There's a lot of commissions that have tried to answer these questions. And so one of the things that we did at the Science Table Congregate Care Working Group was we took all of these, because we said, you know what, we have to stop like doing commissions and asking what was wrong and actually just implement it. And so we were trying to sort of crystallize all of these different things into a sort of simply to say, these are the things that we need to focus on. And so this was out to about January 2022 when we did this work. And so staffing. Yes, we need better staffing. Reducing crowding. So that came from Kai-Hi, and I will be talking about that. Incorporating palliative care, which I won't be speaking about today, but the importance of essential care partners and keeping visitors in, and then optimizing IPAC. So what I thought I would do today is really focus in on the 4 that I think translate directly to IPAC. And just one note, so this is the Alberta Auditor General report that came out in February 2023. So we did not incorporate this into ours because we did it before this, but I did just want to point out, I kind of think number 1, number 2, number 3, number 4, number 1, number 2, number 4, really, and number 5 are really relating to that increasing IPAC and that need there. Staffing, of course, because staffing is such a huge challenge. The crowding and the infrastructure as well. And so I think really, truly, even though they're not quite synthesized the same way, I think we'll be talking to a lot of the issues here that affected Alberta as well. So talking about IPAC and improving knowledge and capacity. So IPAC programs, this is not controversial. They are an evidence-based method to reduce healthcare-associated infections. We've known this for a long time. And in SARS, IPAC programs really took off and were formalized within the hospital sector. So for reasons that I don't understand completely, that did not occur within the long-term care home sector. And so I just wanted to sort of take you through this timeline, thinking if you had people who were thinking about IPAC and long-term care, the many points along the way where maybe some red flags would have been would have gone up. So again, Diamond Princess. So again, I was very focused in the hospital. I had no relationship with long-term care homes. I really was thinking about everything, and it never occurred to me to think about Diamond Princess in the context of maybe this might be a bad thing for long-term care homes. And then the first long-term care home outbreak occurred February 28th. And so again, if you were in long-term care and if you hadn't been thinking about it up until that point, probably you would have started to think about it then. Then on March 8th was the Lynn Valley Center, BC, a long-term care home outbreak, which was the first here in Canada. And I just want to point out, it wasn't until the next day that there was the first long-term care home meeting to discuss the COVID-19 pandemic in long-term care. So I can tell you, I attended that meeting. I don't even remember why I was at that meeting. I somehow got roped into it. And instead of it being the Toronto Region long-term care homes, it ended up being every single person calling in across the province, because there had been nothing up until that point for long-term care. Some corporations had some access to sort of more of a national IPAC infrastructure, but there was nothing. And really, truly, we went through all the things that we needed to have in place. Again, me coming from the hospital sector, which had really been working on this full time since the beginning of January. And it was just like, what are we going to do? So not surprisingly, shortly thereafter, and again, with the benefit of not knowing, really, truly, the long-term care home we were supporting was already in outbreak by then, or just about. And the first formal one was Bob Cajun in Ontario on March 18th. Again, it wasn't until April 8th that the masking went in these homes. And again, it just sort of really just tore through. And it was probably luck if a home did get or didn't get an outbreak, and then it was not really over until the end of May. So the ICPs are the core of any successful IPAC program. And what happened was, sort of from a standards perspective in Ontario, is that every home had to have a named IPAC lead in name. And that person had to do annual webinar or online module, but that's it. And there was no designated time or protected time for this. And truly, it ended up being the role of the nurse, which has tons of extra things that have to come with it within a home. And it was done on the side of their desk. And so effectively, even though there was a named person, it didn't translate into any effective IPAC program. And so in PIDAC, this is our Ontario guidelines, it's always been there, the amount of time that is in terms of ICP time that should be in long-term care, but that was not adopted from a policy standpoint. It's not long-term care homes' fault. These things need to be funded, and there was no funding for this. So one of the best outcomes of our long-term care commission, I think, were the creation of the Ministry of Long-Term Care standards, which are pretty good, I gotta say, for government document. And in this document, it has codified the need to have dedicated ICPs. Now, it's not perfect, and of course, ICPs don't grow on trees, and there's going to be a bumpy road in trying to build that capacity, but at least it is now within a standard, and homes have to do this. And so I think that will be a positive legacy from this COVID-19 pandemic. We also created the IPAC hubs. So this is when all chaos broke loose, effectively, we were just told, hospitals were just told, go in and support. And then in the fall of 2020, this was somewhat formalized, whereby they started to give us funding in order to support IPAC within homes. And I mean, the concept is simple. So within Toronto, we have 5 hubs. And so each hospital has a number of different long-term care retirement homes that we support. And again, it was really mostly focused on crisis, I would say, but now it's starting to build, especially now that there's some IPAC leads within the homes, we can build that capacity. But it was, we had no rules of engagement. It was just like, do this. And so one of the very first things we did, we sort of organized ourselves within Toronto and said, okay, we need to have defined roles and responsibilities if we're stepping all over each other. And so truly the homes retain their ability it's their decision. So they make the decision. It is their accountability to the IPAC within the homes. We, the Toronto Region IPAC hubs, support that and inform that, but ultimately they may choose to accept or not for a variety of reasons. Local public health continue to have their mandate, of course. And then again, the Ministry of Long-Term Care continued with their mandate. And so we all were able to work together mostly in harmony. I think it built additional capacity, certainly wave 1, wave 2, wave 3, all through the waves. It also helps now with building that training within the homes. And again, whenever something unique emerged, whenever there was a new variant, and then also MPOX, for example, whenever there's these new things, you're able to actually educate and tell people and what you need to pay attention to, what is okay. There were PSWs who acquired MPOX, there were exposures within homes. This is something that homes needed to actually know about. But, again, without access to people who are experts, it really doesn't exist. So Whether this will continue, I do not know. We are funded, I think, till the end of March, but I think we'll see. I think it would be great if it continued, but we shall see. There's also need for IPAC guidance tailored to long-term care homes. And so again, I just wanted to highlight in this bullet, I got a phone call. So that day as a member of the NAC IPC saying, there's going to be a problem. We need to get long-term care home guidance at the FAC level. And we put out guidance April 8th. So for those of you who've ever been involved in FAC, this is warp speed. And, I have to say the guidance I think was actually pretty good. Again, that bias, but, it was good. There was nothing else out there tailored to this, this group. And there are nuances that don't translate from the hospital. PIDAC in Ontario, we have now added long-term care membership. So again, it is not something we ever included. The guidance was meant to be for the healthcare sector, so both hospitals, rehab as well as long-term care. But we didn't have any expertise from this sector in informing the guidance documents. And we will be putting out a long-term care home specific guidance document as well, which I think will be really important. The importance of infrastructure. So I think we know this. We know when you have crowding and lots of people sharing bathrooms and whatnot, that of course that's going to increase risk of transmission, but that had not been formalized or articulated in long-term care homes in any way. We know in hospitals the impact of having multi-bedded rooms and the outcome of healthcare associated infections, but this had not been, to my knowledge, studied and until this paper went out. So Kevin Brown, who's an epidemiologist at Public Health Ontario, worked with a group of individuals and created this, I think, kind of neat index called the crowding index. It's not very sophisticated. Effectively, if you have a single room with a single bathroom, that's a crowding index of 1. If you have single room with a shared bathroom, it's 1.5, double room is 2, and then quadruple room is 4. I asked him, I said, what about the 4-bedded rooms with a shared bathroom? He said, I didn't know about those, but crowding, and so in a crowding index of more than 2, so it really, that was the median, and then split it and said crowding index less than 2 is not crowded and more than 2 is crowded. And so I just wanted to bring your attention, it's a crowded table. But so in the crowded, the homes that were crowded, so a crowding index of 2 to 4, they were all 100% of them were built before 1999 when some of the standards changed. And as well, in terms of the ownership, 75% of those that were crowded were private. So that is some of the reason why the private homes did so poorly. And I'm not going to get into private versus public, but the homes in Ontario that are owned in the private sector are largely the crowded ones. And so again, that isn't really a surprise, but helpful to have it articulated. So this is a picture, is worth 1,000 words type picture. So blue are cases of COVID-19 in wave 1, and orange is deaths. And so again, not surprising, but helpful. You can see that the higher the crowding index is, the more cases of COVID-19 occurred, and as well as well as associated with death. And they were able to do simulations that suggested that converting all 4-bedded rooms to 2-bedded rooms would have averted 998 cases and 263 deaths. And so this paper, I believe, is what led to the policy change in wave 2, whereby they did decrowd and had a limit of 2 residents per room, for which we still continue with that. I have to say Quebec has reverted and have gone back to 4, but to date, we continue to have 2 residents per room max. So in conversations with government and whatnot, I kept hearing, but when COVID is over, when COVID is over, when COVID is over, meaning that this was just a COVID thing. And so we were really worried that part of the going back on that policy decision to have more than 2 people in a room would be that at the end of COVID, that they wouldn't think it's a big deal. And so what we were able to show is the impact of crowding on respiratory virus infections before COVID. So again, we knew that we would find something, or we hypothesized that we would find something, but we wanted to demonstrate it. And so again, it's a similar table because same homes, but in that period of time, in that 5-year period of time, there were 4,921 respiratory outbreaks in long-term care, and included in the study with about 65,000 cases of respiratory infections. And again, I'm not getting into our lack of testing and our culture of not testing, but this is probably a gross underestimate of respiratory virus outbreaks and cases within the homes, because they basically got 2 swabs for the year and used them wisely. So in terms of the other reason I like this paper is it actually shows what the breakdown were of the viruses that we saw and their case fatality, because again, so often we heard, well, you know, other viruses don't have this type of mortality. And what we showed was, so in Omicron with COVID, it was about 5%. And see, flu A, flu B is close to 5%, so similar in this population. And then, and as well, human metapneumovirus and multiple pathogens again. So in that 3, 4, 5%. So, and then when we looked at the impact of crowding, again, using that same crowding index, it's even more dramatic, to be honest with you, than what we saw with COVID. And so after adjusting, the adjusted crowding index, it was increased infection, increased death, outbreak frequency, and outbreak size. Again, all of this is intuitive, but being able to demonstrate that this is not a COVID problem, this is actually all respiratory viruses, I think, I'd like to think helped preserve the 2-bedded rooms. It's very exciting to have a CSA standard that is specific to long-term care. So we do have CSA standards now that say that all homes, all newly built homes should have single rooms with a dedicated 3-piece bathroom for all residents. I would describe Ontario as digesting this information. We have 2015 standards that still allow for 2 people per room, and if it is, and also have that Jack and Jill as well. So there are definitely capital implications of this. So these are more expensive homes to build, but probably more impactful and more importantly, the funding mechanism within Ontario has a differential based on private rooms and then the Jack and Jill rooms and then double multi-people ward rooms, they call them. So we're going to have to change the funding stream in order to accommodate these homes, which is going to be an uphill battle. So I'm not sure we're going to adopt this as our standard just yet, but I think it's at least something we can work towards, because we are doing a huge long-term care home building boom right now in Ontario using 2015 standards, which is setting us up poorly for years to come. So staffing. So again, one of the highlights for me during the pandemic on the Science Table Congregate Care Working Group was Dr. Pat Armstrong, who's a professor emeritus at York University, who's a sociologist. And she has said and has coined, the conditions of work are the conditions of care. And I think intuitively we know this. If you work in a poor environment, you're not going to provide a high standard of care. And so we know the evidence strongly supports, and these are HSO standards, which is really around the operating of long-term care homes that came out in 2023, that supports requiring 4.1 hours of daily care. I think within Ontario, our target for next year is 3 hours of care. So we're still falling far below that. And that's an average. So again, they're not doing it at an individual level, which has been critiqued. But again, it's something for us to shoot for. So why am I talking about staffing when I'm talking about IPAC? Well, there's a whole host of things that we learned affected IPAC. So the agency workers. So if you have people coming in, so there's one home I heard about up in Northern Ontario that actually has 80% agency. So it's a different person. So you can't train IPAC when you have different people coming in. How are they going to know the IPAC policies within that home? You can't. Also high staff turnover. So there is enormous high staff turnover. So again, once you educate, then you lose it. And so again, it is a revolving door. And so clearly there's need to have that workforce stabilized. Working in multiple homes. So again, that was a huge issue at the onset of COVID, and certainly I'm sure affects all sorts of different infections. People need to cobble together different jobs in order to make a living because we're not paying them a living wage. And accordingly, then you're going to have spread. So that was a huge issue at the onset of COVID. Limited staffing redundancy. I've already alluded to some of those challenges, but again, you know, if you only have an N of 2, N of 3, N of 4, and all of them become sick, then what are you going to do? And as well, the need for occupational health. So again, there is no occupational health. It just doesn't exist. Again, some large corporations have some occupational health built into it, but truly, who is doing the resident screening? Who is sending that person home? Who is clearing them for work? Who's bringing them back? We don't have that. Who's making sure people are vaccinated? It just is absent within the sector, which was, again, a huge learning. So the role of the essential care partner, I think certainly I've done a lot of learning about this, this piece through the pandemic, and in particular, the impact of shutting out essential care partners. So again, in Ontario, and I think it was similar in other provinces, March 13th, we stopped all visits, none, zero, until June 10th. So there was no visitors at all, with the exception of if somebody was dying. And so I'd say that probably one of the things I'm most proud of in the COVID-19 pandemic was, again, working with the National Institutes on Aging, which sort of does some policy work. And we were able to, so led by Nathan Stahl, who's geriatrician at Sinai, we were able to put together a document that says finding the right balance. So again, an evidence-informed way in which we can let essential care partners back in a way that's safely. So what happened was my grandmother, who was had advanced dementia at the time in PEI, at the time that this document came out, and they still weren't letting in caregivers. And so my grandfather asked my dad to print it out, and then brought it to the administrators there at the home and said, listen, you know, this is my granddaughter, and what she says is right. And right then they then started allowing essential care partners in. And so again, I think that it was influential and helpful. And again, not that I'm taking any credit for that, but again, at that home, yes. But you know, really, truly, I have made the analogy that this is like the pediatric patients. You can't shut out parents. You cannot. And, you know, if people say, what about Ebola? I said, what about Ebola? Truly, 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 I think it's up to us to find a way to make it safe rather than on the onus on those individuals. We cannot shut out essential care partners. And the impact of this cannot be overstated. So again, residents, this is well documented: acute loneliness, depressing mood, behavior issues, worsening signs and symptoms of dementia. Essential care partners, I mean, imagine that moral distress of not being able to come in. Staff, so their workload at a time where there was no staffing went way up. And again, and truly also not having those indicators of the resident, you know, this is not normal for them. This is, you know, these acute changes, not noticing, not having that ability. And then again, so how do you balance this? And we do not yet have a framework for how to balance the visitor aspect, both in hospitals as well as long-term care homes. And I do hope that that is an area of work. I mean, I think actually when it comes to ECPs, I think it's easy. I think we just can't shut them out. But I do think we need to find a framework, because I can just imagine first case of avian flu, same thing's going to happen again. I know that that will happen. So we need to figure out how can we mitigate this and offer up a solution. And the last point I'm going to make about this again is just sort of to data quantify it. What we saw again, this is more work by Nathan and team. Really, truly, these drugs, the drugs went way up. So the line here is the wave 1 onset of COVID-19 pandemic. So again, antipsychotics went up, benzos went up. Oh, I can't see what the one at the top, and then metformin and statins went down. So, you know, you can just see the impact of COVID-19 on directly on the impact of these drugs and prescriptions. So where are we at? So we are overdue for a flu pandemic. Nobody likes it when I say that. I know, but we are. The reality is we're overdue, and having COVID, I don't think counts. Like, I don't think it means you get a pass for the next influenza pandemic. And certainly we know H5N1 is percolating out there. I don't know if it's going to be that or something else coming as a surprise out of the blue. COVID-19 in the fall, I think, will be fun in the context of few, if any, public health measures in place. And then a Candida auris. So again, this is my uplifting part of the talk, but how much we've learned. So again, if we're going to, this is a quote from a recent BMJ article that was a commentary by Dr. Karen. So if we're to be ready for the next pandemic, we can't fall back into the same cycle of panic neglect, which is exactly what happens. And for those of you who've been involved in IPAC for a long time, this is our life. However, I think when it comes to long-term care homes, we really have to find a way to do better. So the learnings, again, need for a robust IPAC program. I am happy and feel somewhat optimistic about the standards that we have in place now in Ontario. Whether the hubs will continue, I do not know. I think they were great, are great. But again, whether they will continue that, I don't know. Improved infrastructure. So again, from a policy perspective, at least maintaining 2 residents per room, that has been now codified at this moment in time in Ontario so that we're not going back, which I think is helpful signal for now. Memories are short, but remind that Quebec did go back on that. So they still do have 4 beds, 4 residents, they now have 4 people per room or can have people per room. And we have to figure out a way financially to implement the CSA standards as our standards. So, you know, for those of you who don't work at IPAC may not be familiar with the CSA standards, but really, truly, that is our true north. That is what we follow for our construction, certainly within the hospital sector. So how can we shift it that becomes the standard and the norm within long-term care? But it's money and operating funds again in Ontario. And so how are we going to find a way from that? Manitoba has signaled that they will be building only private rooms. I've not figured out how they're going to then fund it. But I think that it's something that we need to be moving towards and certainly need advocacy. Staffing, I don't pretend to know the solution to this. I think everybody knows this is a problem. The solutions are harder to find. But I will say that I think it would be helpful. And I do think you have this better in Alberta. As you function in more so as a unit. I know I'm not being naive here. I understand there's limitations. However, in Ontario, each hospital is its individual corporation. Each long-term care home is an individual corporation. There's nothing that's saying that people have to work together. There is no system in that way. And so how do we make it so that we help this sector when they are in need? We don't function like that. We're not designed like that. And so I think that needs to be better defined because there will be more crises. And what is the role of the healthcare system when that occurs? And then the role of the ICP, I've said it already. I do think we need an ethical framework for ECPs and visiting in the times of these high consequence pathogens, which will happen again. COVID-19 in the context of few, if any, public health measures in place. So again, right now we have this little window where it's kind of nice, but the fall is going to come and it's going to get worse again, both for COVID as well as other respiratory viruses. So clearly needing systematically ensuring that residents are offered vaccination and get their boosters in a timely way, as well as staff. The role of universal masking, I can read the tea leaves, whether I'm sure it's going to go away soon, but whether or not it'll come back, what are the thresholds to come back? It would be great if somebody could come up with that, Dr. Geoffrey. And I would say, I think that there is a role, but whether once it goes away, whether we'll ever be able to get it back, I don't know. I also don't know how bad it's going to get before anything actually moves. I think it's going to be a real challenge. How we're going to deal with this, I don't know. Mike Freilich, a colleague at Sinai, has done some interesting work, which is really just swabbing the environment. And what he was able to show by swabbing at least, sort of 30 places within a home, right on a repeated basis, was able to demonstrate that he and his team were able to predict outbreaks before the onset of symptoms or before the PCR testing occurred. And so you can define thresholds of like what's going to be your trigger. And so if you define a threshold of 10% of the swabs positive is your trigger to do something, that had a sensitivity of 94% and specificity of 53%. So, maybe it's something, again, I think in the fall, we're going to be in big trouble. So I'm just sort of mentioning, I'm like, I don't know what our solution is going to be. So I think we're going to have to think of alternative options and think outside the box. And I'm just mentioning this one that I thought was kind of interesting. I'm going to finish on Canada Auris. So this is going to be a big problem in long-term care, can guarantee it. So it's already affected. So Canada Auris, a multi-drug resistant Candida, which I think most of you in this room are familiar with. It is an issue already in the US and has really blown up over the course of the pandemic. Pre-pandemic, there were already some long-term care home outbreaks, and again, now we're just seeing them being described as at increasing frequency. Some of our colleagues were down at Shea, and they kind of laughed and said, you have it, you just don't know you have it yet, which I think is probably accurate. And so again, this is going to hit us quite hard. So FAC put out a notice December 2022, which I think was actually pretty good. But what I will just share is how underprepared long-term care homes are for this organism. So it says patients being admitted to hospital and long-term care homes should be placed preemptively on contact precautions and screened for Candida auris if they've been admitted to a hospital or long-term care home outside of Canada within the last 12 months or transferred from a Canadian healthcare facility with an ongoing Candida auris outbreak if known. Well, at this moment in time in Ontario, not a single home has the ability, is not connected to anyone that can actually screen. So we are unable to do this screen. It also costs money. So there's no funding for that. So who's going to pay for that screening? Environmental cleaning and disinfection of a room of a patient with Candida auris should be done using Health Canada approved hospital or healthcare disinfectants with claims of efficacy against Candida auris. So in long-term care homes, as we found, many people use quats. Quats do not have activity against Candida auris. And so again, you can just see this happening. So it's going to be like spreading silently and this home's using quats, and it's just going to continue to spread. And then it says all healthcare facilities should be able to manage patients with Candida auris, and Candida auris colonization infection should not be a reason to refuse transfer. Well, I've already told you, we have no ability to screen. We don't have the right disinfectants in many cases. We don't have any sort of knowledge or capacity within these homes. And so again, you can just start to see in Ontario, it's not even reportable. So there's not even ability to do like any sort of network or contact tracing or anything. So again, we are using our voices and raising the alarm, but we'll see. I suspect it's going to hit us first and then we'll react. And it speaks to a larger problem of AROs in long-term care homes in general. So there is no standard recommended ARO screening in long-term care home or set expectations, and there's no funding for this. So again, as a hub, we can say, well, you really ought to be screening for MRSA, VRE, and CPE, but they say, and are you going to pay for that? Thank you very much. They're not. What is the surveillance expectations? What is the reporting expectations? Again, these are not reportable things. CPE is in Ontario, nothing else is. So, you know, again, they'll say, well, you want us to spend all this money on something that, you know, nobody's paying attention or cares about. And then support for outbreaks. And again, that's where I do think the hubs will play a role. Like first, define an outbreak, find the outbreak, define the outbreak, and then again, provide that support. And then just a note about stewardship. Again, that's a whole other conversation. But we know that long-term care homes are a reservoir for ARO, and there's high levels of antimicrobial use and inappropriate antimicrobial use. And so again, having a strategy for ASP is key. So in conclusion, I wanted to make sure we had time for discussion. COVID-19 has exposed longstanding IPAC gaps in long-term care homes. There is work underway to improve it. I think we really have to remind people, because the memories are very short, as I've learned, that is needed and how to get it into policy, because that is the way that you can preserve these changes. But there is, it's clear there's far more work that needs to occur to improve IPAC within long-term care homes and many threats and challenges. So I did just want to take a moment to acknowledge. So again, this was like a total sidebar to our COVID-19 journey. I never worked in long-term care before the pandemic, and now I have spent quite a lot of time in this space. There is a lot said about people working in long-term care, and I just want to say that it was our experience that the staff were just working their hardest, and they were dealt a really bad hand and really did our best, at least in the cases that we learned. Some slept, some had slept there for weeks on end. In some cases, funeral homes wouldn't come into the home, so people had to physically carry people out. Like, it was awful, and these people stuck with it, or many stuck with it. And again, they put their own home, themselves at risk, and they really did their very best. And so I think it's just important to make sure, there are bad stories out there, there are many, many, many good stories. And there are many that continue to work in the sector, even though it is an incredibly challenging place to live. So I also just want to acknowledge the residents and their ECPs who were irreversibly impacted by this pandemic. So with that, I will open it up for for questions.
Thank you, Jenny. Amazing talk, very sobering, many challenges ahead. So yeah, we'll open up to questions in the audience.
So thanks, Jenny, so much for an incredible overview and presentation. Let me just say that Jeff would have been extraordinarily proud to be able to hear that presentation. I've got lots of questions. So I'm going to confine it to two. So I appreciate, first of all, the focus here was long-term care, infrastructure and long-term care, need for private rooms, or at most 2 per room. How does that translate to acute care? And over capacity beds, I don't know what you call them, stuffing people in the hallways and extra beds. And then my second question, are you optimistic?
So great. So two questions. One is, I think if I could rephrase it, just say it's like balancing the burden across the healthcare sector, in that, we have people piling up in hospitals, in hallways and whatnot. And understanding that, we could open up and have 4 people in a room, for example, and that would alleviate, which is the decision that Quebec made. So how do you balance it? I guess my response to that is, it is not on the backs of the long-term care home residents. So yes, it's a problem. It's a problem that the healthcare system needs to solve. But I think that many people are getting older, and you start to think about your parents in these, and I think we need to do better. And I think we need to find the balance. And I can live with, 2, not 4, at looking at the risks that are imposed there. But I would say that this group suffered a lot through the pandemic, and we're setting ourselves up for another disaster. And if we can't learn anything, yes, we need to learn. We know in acute care that we need to do better as well, but I just don't think it can be done at the expense of our elderly. Like, I don't think we can do that. Am I optimistic? So in speaking with people who've been in this space for a long time, I would say they tell me not to be optimistic. I will say that I am realistic, and I think it's important that people who are in a position to use their voices and use data and try and make sure and maybe take the small wins. So for example, having it in a standard that the minimum amount of IPAC, having IPAC time dedicated to IPAC is a win, because that is something that will be enforced. So I think that is something that is good. I think that it continues and will continue to be an uphill battle, but I think it's baby steps. But it is hard. It's very hard, and it is really things stacked against, for sure. Especially because you added in the whole private component, and people who are making a lot of money.
Jenny, thanks for a fantastic talk. I want to ask you a question about the staffing and screening staff. So there's pretty good evidence that multi-virus was introduced into the home by the staff, since they allowed no one staff at some point into the institutions. And many of the staff, as you know, are not well paid. That's what they need money. So if you rely only on self-screening, it's very easy to answer the question, because you need the job and you need the money. You can even take antipyretics before. What I never understood is when we finally got antigen tests, they, in my opinion, they were very misused. And I thought one of the ways they should also have been used was screening people and workers every single day they walk in. So I think self-reported screening for people who have, conflicting interests is not very reliable. And what are your thoughts of, should we have screened them every day as they came in with an antigen, as imperfect as it was?
Well, so I mean, I have a complicated relationship with antigen screening in my role as provincial strategy expert panel chair. And so again, I would say this. So there is a New England Journal of Medicine paper that actually came out and did demonstrate that there was benefit. I did write a letter to the editor, though, which is I think will be published at some point soon. But I think that it may have overrepresented the amount of benefit, because the homes that saw the homes that didn't do the screening were also the worst homes. And I think anyone who's now worked in this sector knows, like, there's good homes, there's bad homes. And so what they said was the volume of tests, the number of positives in the good homes was evidence that, you know, that this was effective, or demonstrated that it wasn't an issue with like that there wasn't an issue with the actual homes or the infrastructure, all these things that we adjusted all that out. And I just made the point that, you know, again, we see a lot of positive tests and we don't know what the effect of that is necessarily. I just don't think that you can say that that is a reason that you fully adjusted all of these other really bad aspects of the homes that were completely different within the good, you know, good testing homes, the bad testing homes. So I would say the other piece of it is for the staff so in Ontario, we did test. So first it was PCR testing once a week, NP swab. No, but this is what they went through. So they went through NP swabs once a week, followed by rapid antigen testing. Then we did it 3 times a week, I think. And so for 3 years, they had this done to them. And I'd say that one, they had to divert resources in order to support this. Lots of resources, actually, that they were spent doing this. Number 2, I don't know how well it was done. You can imagine. And number 3, sort of, they just said, like, why are we the only ones that were doing it? And so there was not really a fairness component. We didn't do it in healthcare. We didn't do it in any other sector. We only did it in these individuals. So I guess the answer is, I don't know what the answer is. And I ask myself that a lot. Should we have done it? Was it a good thing to do, a bad thing to do? The New England Journal paper suggests that it was a good thing to do in wave 1, 2, 3, and less good once we hit Omicron. So the answer is maybe, but I also think that we could have used those resources to making sure that we actually wore our masks and properly masked and because again, even if you show up sick, the risk of you transmitting were far less if you actually followed all the other pieces. So if I were to do it again, I do think there is a role. I don't know about daily. I mean, there's an element of cruelty, to be honest with you, at some point, if you had to actually have this done to you every single day. But I would say that there is a balance. I would probably just prefer to fix the underlying causes, but understanding the underlying issues, which is like people have to come to work to live and get that. I don't know. I'd say that probably there is a role, but I think we have to think about it in a broader sense. And I kind of want to think it through so that when this happens again, I mean, it would have helped if there were a lot better tests. Like, there's a lot of problems with them too, but I don't know that I ever would have said to do it every single day, because then people also left, right? So you had to balance all these pieces. It's a complicated issue. No paid sick leave. Are you kidding me? That's right. That's right. Exactly. So Lenora is just making the point. You know, they don't get paid if there's so again, like if I were in charge, I would have done it differently. So that isn't how I would have spent my resources. However, knowing that you're not going to fix the system, how do you work within the system? Is there some sort of balance there? And I think the answer is yes, there is a balance, but I think you have to think through all the other elements of it. And I do think there was a bit of a cruelty element.
Maybe we'll just take it as a question from our virtual audience from Wendy Vaudry about cost effectiveness analysis.
Ooh. We didn't do the cost effective. It's a great question. So it says, how to justify the standard of 1-bed room? How do you incorporate this into a cost effectiveness analysis? So I don't know. So we haven't done a cost effectiveness analysis. However, given the trajectories that we saw, so for both COVID, influenza, RSV, and all the respiratory viruses, plus we didn't do the analysis for norovirus and all the other healthcare-associated infections. Healthcare-associated infections are expensive, and so again, they did do the offset from 4 to 2 beds, which would have avoided 998 cases and 238 deaths. So I don't know, but I think it would be cost effective. But I think perhaps if that's something that policy makers need to see, that would be helpful. The problem is the POTS those are not the people who pay. So I think it's helpful, but you know, the people who are funding the building of the long-term care homes are not the ones who are paying for the healthcare system. So I don't know. I don't know if it's going to help move the needle, to be honest with you, but maybe.
One more question at the back, Anne.
That was fabulous, Jenny. Thank you. I'm a little closer to long-term care than. I really appreciated the advice of private and public.
Mm.
And I wanted to ask a question and looking at congregate places like. Is there any role for duty like?
Oh, UV light. So the question is within congregate care, any role of the UV light? So, I mean, I think we can look at everything. I can't stress enough how worried I am about the fall and what we're going to do when no one's masking, and like it's going to be really challenging. So I don't know of the evidence supporting that necessarily alone, but I think we should be looking at everything.
Okay. Thank you very much, Jenny. Thank you very much, Jenny. It's a fantastic talk. And I want to thank all of our speakers today. So Dr. Lemieux, Dr. Johnstone, as well as all of our trainee presenters. This has been a fantastic morning. It's great to see all of the research that's going on in our division and hearing our expert speakers as well. So thank you all as well for attending both online and in the room. And we will now, for those of you in the room, have lunch, which I think is set up outside. And again, have an opportunity to chat with our friends and colleagues. Thank you again all very much.